next speaker, Dr. Pradeep Kumar. He will be speaking instead of Vinod Agarwal, and he will be dealing with supine position for post-RD cells.
Very good evening, everyone. I am presenting this topic on behalf of Professor Vinod Agarwal, and thank you for this opportunity. I'll be speaking on an extremely counterintuitive topic right after the first one. So we are talking about supine positioning after RD surgery. So tamponading agents have been used basically for providing surface tension across the retinal break, to maintain the intraocular volume post-op, and to create a rhegmatogenous confinement for the retinopexy to take effect. Now, these patients were post-operatively placed in prone position. But most retinal breaks commonly develop in the area which is anterior to the anterior to the equator, and they will be better tamponaded in supine position. So this was the thought process. In the first slide, you can see that when the eye is 100% gas filled in prone position, the anterior breaks are quite well supported. But the moment this bubble falls to 50 to 60%, those breaks are likely to be unsupported. But if you place the patient in a supine position, you will realize that these anterior breaks will remain supported even when the tamponading bubble becomes smaller. So there was one single prospective study which had examined this supine versus prone positioning earlier. So we designed this prospective study with a primary objective to study the anatomical outcome and a secondary objective to assess the best corrected visual acuity, the IOP changes, and the change in the phakic status of the patient. So 72 eyes of 70 patients were randomized, 37 in one and 35 in the other group. Our inclusion criteria mainly involved fresh RDs, patients with PVR less than C2 grade. And we avoided younger, extremely young and older age group so that whichever positioning we gave to the patient, it could be adhered to persistently. We avoided combined RDs, so we chose these patients of fresh RD presenting to our OPD. Those meeting the inclusion and exclusion criteria were recruited. PPV was done in these patients, and they were given their supine positioning or the prone positioning, and these patients were assessed at 1 week, 1 month, and 3 months. So this was the standard surgical technique which was done in all these cases, and the choice of gas remained between SF6 and C3F8 based on the surgeon's discretion at the end of the surgery. This very cluttered slide talks about the preoperative status of this patient. I'd like you to focus on para 10, where we talk about the number of breaks. These were primarily patients with one break, and the position of the break was mostly superior, but yes, in both groups. 8 patients in group 1 and 7 in group 2 had inferior breaks also. The primary outcome was that 36 patients, that is 97% in the supine group, remained attached at 3 months. There was one redetachment, and 33 patients, that is 94%, remained attached in prone group. There were 2 redetachments. There was no statistically significant difference between these two. This figure of 1 and 2 is too small to say that there is a difference in the outcome in supine or prone. So they were comparable results. When we talked about best corrected visual acuity, the groups fared similarly, and so did the intraocular pressure. So the plausibility of supine positioning with gas causing a rise in IOP was not there. 3 patients in supine and 7 patients in prone position underwent cataract formation and later on surgery at the end of 3 and 6 month period. The post-operative complications were comparable between the two subgroups. There was formation of ERM in 2 patients in supine and 3 patients in prone group. There was neurosensory detachment. These were the cases which had those redetachment, 1 in supine, 1 in prone. CME occurred in 2 patients in supine, 1 in prone. Vitreous hemorrhage was seen in 2 of the prone patients, and macular hole developed post-operatively in 1 patient in each subgroup. So they were all comparable. So these are examples of what happened to these patients pre-op and post-operatively. So these were single horseshoe tear, they were lasered well and have settled. And to conclude, we'll say that single surgery retinal reattachment was similar in the 2 groups. There were no increased complications of cataract formation or IOP, which were suspected by many patients many of our colleagues when we were discussing this idea. And both the positions work well. One should be encouraged to try supine positioning in at least some of their patients. The limitations of this study have been its small sample size and less number of patients with inferior breaks. To end the study, this is one video that Dr. Vinod has tried to submit where he says that once you introduce tamponade, this kind of turbulence which you see inside the eye, that gets settled down once air keeps filling the globe. So he says that once air has gone in and the turbulence is settled down, see, once the air enters, you are seeing the movement of all those detached ILM peel fragments that stops. So once you do not have turbulence inside, supine positioning will work as well as prone positioning. There have been a lot of critics to this, but our publication is now in retina and will be out soon. Thank you, sir.
Pradeep, it's a little surprising that the supine positioning caused less cataract than the prone one.
Exactly, sir. When we were discussing this idea, that is what everybody said, that we will have a lot of cataracts in our subgroup, but it did not happen that way.
Phakic patients was the same in both the groups.
Yes.
Actually, you need to analyze the number of breaks and the position of the breaks also while having the results.
Sir, that is where that slide I had shown para 9 and 10. The position of our break in both the subgroups were in the superior half in almost about 3/4. But in 1/4 of the patient, they were inferior or temporal or nasal. So that is.
Superior breaks do not matter whether which position you are giving, but the inferior breaks actually matters, and probably you need to do a subgroup analysis to authenticate your proposal.
Oh, yes, sir. In fact, it's no longer a proposal, it is a completed study, sir, and it's been accepted now.